Hello, everyone, and welcome to TEDMED Great Challenges. Today's live event will look at discussing achieving more medical innovation and through more affordable means. My name is John Nasta, and I'll be moderating the discussion today, which will last, about an hour. This session is part of the Great Challenges program and sponsored by the Robert Wood Johnson Foundation. The goal of Great Challenges is to look at 20 pressing issues, complex health and medical issues in the world today, and begin the dialogue to discuss them and engage communities to a greater level of understanding. We're not looking to solve these problems. We're looking to build a dialogue to move these issues further. We'll be taking questions to solve some of these issues, or try to solve some of them, and sharing ideas with a variety of disciplines. So people who are on Facebook, Twitter, and the Google Hangout are encouraged to submit questions. This is part of the broader dialogue that's essential to the success of these programs. At Twitter, it's at TEDMED, and just tag your questions with the hashtag Great Challenges, and we'll do our best to get them to our panel. As mentioned, my name is John Nasta. I'm Executive Vice President and Senior Strategist with Ogilvy Common Health. Today, we are delighted to have a very robust panel to drive our discussion forward. I'd like to just quickly introduce them and go around the table. Margaret Anderson is Executive Director of Faster Cures, the Center for Accelerating Medical Solutions. Dr. Lisa Bilamovich is the Senior Vice President and Physician for Strategy at the Advisory Board Company. Her current work features progressive hospital physician alignment and partnerships. Additionally, Stacy Cheng is joining us, an Associate Partner and Director of Health and Wellness, the practice at IDEO, where he crafts new offerings in everything from therapies to research. Diego Morales joins us as the head of Janssen's Healthcare Innovation, where he oversees initiatives that will improve the consumer healthcare experience and achieve better outcomes. Amy Puliafito leads the marketing content at Rock Health, a seed accelerator for health startups, empowering the next generation of technologies to help transform health. And Don Rucker is the Vice President and Chief Medical Officer at Siemens. His innovations there include award-winning computerized physician order entry systems, as well as interesting imaging and diagnostic modalities. So let's start off our discussion today. I think it's fair to say that innovation is here. Wherever we look, we see oncological innovations in the treatment of lung cancer. If we look out to the West Coast in Las Vegas, we see the Consumer Electronics Show, where innovation is quite common and almost ubiquitous. Unfortunately, in today's health world, innovation shares a border, and that border is cost. And I'd like to just spend a little bit of time framing up that discussion. Innovation is a necessary advance in clinical medicine and the practice of therapeutics, but it's often expensive and a difficult obstacle for many people. So I'm interested, maybe Don, as an industry perspective, when we look at tremendous advances in imaging modalities. How do we manage that? What's your perspective on that, and what's the future look like?
Well, I think there's two things. And one of the problems, obviously, with expense is that, at least in the United States, because effectively Medicare sets a lot of the prices, a lot of the things are sort of mispriced and priced in funny ways that you wouldn't, for example, see in Silicon Valley. So I think that's one thing. The other challenge, I think, with innovation is often we're not doing the accounting quite right. So we look at something, and I'm just going to take one of the greatest innovations, which is CT scans. And let's drill down to abdominal CT. We sort of see the cost of a scan, which maybe is, let's say, $400 at Medicare. But what is not necessarily accounted for is now, if you don't have appendicitis, we don't have to admit you to the hospital with all those costs. If you do, we can take you to surgery without doing any exploratory surgery. So folks who were in the past admitted are now discharged. So the costs are often radically moved from one spot and greatly reduced, even if the innovation itself maybe costs more. We don't have great healthcare cost accounting. So I would say that's a challenge maybe we can solve.
That's an interesting perspective. So I guess you could say that the true cost of innovation is rather ambiguous because you're looking at cost savings, particularly with an example of appendicitis. So is that a disservice in the community? Are we not explaining the value of innovation and just relying on the high cost of a particular intervention? Maybe Diego, you can jump on that one.
So one aspect that is unique about the healthcare industry is, while those of you that are old enough to remember what a VCR is, I mean, you bought a VCR and you paid $1,000 for a VCR. Was incredibly simple. At the time that the VCR died, you could buy a VCR with unbelievable features for $100. All right, it was 100 times better than the one that you had bought 10 years before. If you look at all the technology we have in your cell phones, your computers, everything is constantly improving in terms of the capabilities that it offers, but the cost is always going down. I mean, that's the way that it works. Healthcare is unique in that every added feature increases the cost. If you buy, let's go back to any machine, any piece of imaging or any diagnostic that you can think of is a lot more expensive than it was 20 years ago, and that's pretty unique to the healthcare industry.
Interesting, Diego. Let me jump in. Are there examples where we can look at some success stories, some prices that have actually fell either in diagnostics or therapeutics? And I challenge the group to chime in also.
Well, the generic. I mean, I work for Johnson & Johnson for a company that, among others, has a large pharmaceutical group, and you could think that we develop fantastic branded drugs, and when those drugs go generic, they become fantastic generic drugs that are sold for a fraction of the cost of when they were branded. And then the reason why the industry works that way is because you have to pay all the development costs, which are immense, as you know, is well publicized. It costs you between $1 and $1.5 billion to get a drug to the market, and you need to amortize those costs over the period of the patent exclusivity. But after that patent exclusivity goes away, you can buy Lipitor now for $5 for a 3-month supply at Walmart. I mean, so that shows you an intervention that has a dramatic decrease in price with time and through the way that the industry is set up.
Interesting. Margaret, we talked earlier a little bit about how innovation is a bit more complex, and sometimes innovation is about better managing a system or a process. Tell me a little bit more about that, particularly in the area of cystic fibrosis.
Well, so, I was speaking earlier that I think that we need to look both at innovation in terms of new treatments and new cures, but we also need to look at how can we do what we know better. And so I think that you've got both of those things going on right now, and certainly there's a lot of robust discussion about how we're delivering healthcare. Is it efficient? Is it providing value? In the case of cystic fibrosis, though, what I would like to share is that there are innovations happening, and people in the medical research community are paying attention. So this year, or in 2012, there was an approval of a drug called Kalydeco by Vertex Corporation. This drug would not have happened without the significant participation and funding of the Cystic Fibrosis Foundation. And CF Foundation is an example of a venture philanthropy group. These groups are really bringing passion capital to the table, and they're bringing really smart science and patient involvement. So I would posit that innovation can't happen unless you're bringing the end user to the table to be part of it.
Interesting. So, Lisa, I want you to talk a little bit about the collaborative process, because I think what Margaret articulated is that innovation is exactly what we're doing here. It's a collaboration of people thinking together and, in fact, working together. I know that your involvement, particularly in the patient-physician collaboration, is an important element in both innovation, but also I want you to address potentially cost-cutting or economies that may result in this collaboration.
I think Margaret's point about a lot of the innovation challenges that we need to conquer are not just about finding something that is new to treat a disease or solve a patient problem, but making sure that we are doing the things that we already know how to do very well. When you look at the most pressing problems facing healthcare today from a cost and quality perspective, a lot of them are our baseline chronic diseases, obesity, diabetes. Take diabetes, for instance. Primary care physicians, nurse practitioners, the folks on the front line know how to treat a diabetic patient. The challenge is engaging patients and bringing them in to be part of the process to make sure that all patients receive the 3 visits that they need per year, to make sure that they are on meds and under control. And some of the most compelling innovations that we are seeing are devices, technologies, solutions that connect the patient to the provider, connect the patient to a community so that they are engaged in the same treatment pathways that we know are the right way to treat a chronic disease patient, and just haven't had a way to make them sticky. And if you can have a low-cost innovation that glues the patient into what they need to be doing, will save costs for the entire system.
Okay, Lisa, fascinating, and I think you're spot on about the way we can leverage ideas to sort of make them stick to the roof of a clinician's brain or a patient's brain. But you touched on something interesting, the role of the patient. As we see the empowerment of the patient now with new devices, with new technology that make them more active in care, how important is the patient in terms of driving economy? In other words, being a more active player in their care to help drive costs down. And we can go around the table a little bit on that because I think different perspectives would be important.
Yeah, I think this is a critical issue because when you look at historically, I'm a physician, Don's a physician, when we were in training, largely the patient, let's be honest, took a very passive role. They were the object of doctors' orders that were carried out by other people. I think we are finding patients beginning to demand, and of course I think that, largely it was the explosion of information that's available at patients' fingertips via the internet that began to change this. They need to be an active part of the care team. But it puts a huge burden on providers to figure out the right way, the right information level, the right type of engagement that is right for each kind of patient. Obviously very, very different for a tech-savvy patient than for a patient of low education and low means. So I think that is the critical challenge that we have in front of us, but patients are demanding it, and I think if you look at where healthcare reform is taking us, which is going to be expanding coverage in a way that puts more decisions in the hands of consumers, that we're going to see more and more patients making choices about how their healthcare is purchased and what services they are receiving. And as Don kicked us off with, decisions follow the dollars.
Yeah, maybe I can pipe in for a second. This is Stacy. I think we're seeing that tipping point happen already, right? You look at examples of, most people have probably seen the example, the TEDx talk from Hugo Campo. He's just the leading edge of consumers taking a really active role, actually driving the healthcare system to be more open and transparent about the data they share, because there are individuals who right now are the leading edge who want to be actively involved or hacking the system in order to create that engagement. That's just more what will come. And so, I think the discussion isn't if, it's about when and how fast, really, on the patient front.
I want to get back to the patient engagement because it's an important element. It sounds like patient engagement is an essential tool to embracing innovation and driving costs, but I wonder if it becomes increasingly burdensome for the caregiver, whether it be the nurse or the physician, to become technologically savvy and even being able to communicate how best to use these devices. Lisa, in the context of patients working with physicians, is this a hurdle that we have to get over? Is this a stumbling block?
I think that this is a huge hurdle and one that, honest moment, the system has not figured out yet. we're on the verge of a patient information and patient data explosion. If you think about all of the information we'll be aggregating in electronic medical records and other patient information sources, coupling that with the growth in monitoring devices, whether they be medical devices or the consumer-driven devices. I know of a lot of patients that are now more actively involved in fitness than they ever were before because they are attached to their Fitbit. How do we synthesize all of this information together, and who's going to own it? Who's going to do that analysis, and who's going to feed it back into the hands of a provider so that it is in a usable, actionable format? That's what's critical here. If there's one thing that that physicians, particularly those primary care docs and nurse practitioners at the front lines, aren't going to be able to do is to sort through all of this information. The entity that can take this data, put it together, and create usable, actionable information for those frontline providers has a great market open for them.
So let's jump over to Amy now, because I think we're going to go from clinical medicine to the clinical startups, and we know that there are roadblocks ahead. And I'd like you to speak, Amy, a little bit to the notion of seed acceleration of startups in some of these devices, some technologies. In your perspective, does the answer lie in some of these small innovative companies that are merging with new technologies and innovations?
Sure. Yeah, so Rock Health, for those of you that don't know, is a seed accelerator for health startups. And what we do is we try to give not just funding, but also operational support, mentorship, access to a network of partners to early stage healthcare entrepreneurs. And an integral part of our mission is not just to provide people with resources that they need, but also to break down the barriers for people who are outside of healthcare and who could be valuable players in innovating, break down the barriers for them to come into healthcare. So really to attract human capital and talent. And I think that's one of the things that we try to do as an accelerator, and is also really valuable for the entire healthcare industry.
Amy.
So we try to bring in great software engineers and hardware engineers who may have not previously ever worked in healthcare.
So you mentioned something interesting, Amy. We bring in the smartest engineers and technical folks. But I want to get a perspective, and this question comes from Facebook, so thank you out there for reaching to us here. Your questions are encouraged. Simply put, what is the role of academia and government to enhance some of these initiatives that are largely mediated by VC and the private sector?
I think that's a pretty complicated question, but at Rock Health, we see academic partners as an integral part of sort of facilitating innovation, and we have a variety of really outstanding academic partners that facilitate pilots for a lot of our startups, and we have a lot of our startups also have come out of academia themselves, are medical students who have worked with professors or advisors at their own medical schools, and I think that those have been really valuable partnerships that both our entrepreneurs and ourselves have formed. I think the government also plays an important role, but I think it also really remains to be seen how a lot of these technologies are going to be, these sort of new technologies and early stage ideas are going to end up being regulated. So far, I mean, I think we've seen some promising news, which, I mean, a great example would be the AliveCore ECG, which, its 510K approval took about 90 days. So I'm feeling very optimistic about it, but I think we're going to have to wait and see exactly what happens. And I think there's some promising signs, but we have to kind of just wait and see.
So Amy, I'm gonna keep asking you hard questions.
Great.
And I'd like to understand, and I know the answer is a little bit of both, but maybe the panel can talk about this. What drives innovation? Clinical need, clinical necessity, if you will, or cost? Where do you see, and we'll talk about sort of the VC private dollar market, are people looking to make things less expensive, a conventional therapy that already exists, or are people to look at a conventional therapy and make it better? And Don, maybe you can follow up a little bit on imaging, where it seems to be bigger, brighter, smarter, and more dynamic.
So,
sorry. No, Amy, go.
So I don't think I can really speak to innovation in therapeutics. As we sometimes say in digital health, we don't do drugs. So, so if you can just kind of speak a little bit more about what the question was again. I kind of got distracted for a second. Can you just remind me what you were asking? Sure. Sorry, John.
What is driving innovation?
Driving innovation.
Is it so dollars?
For us, we think it's cost. So I think for a lot of people, healthcare reform was a big driver about getting people interested in healthcare innovation. But I think, especially with patients, just the number of people that were going bankrupt due to healthcare costs was so high, and the news around this and just general dissatisfaction around this was really getting people thinking there's got to be a better way. And so at Rock Health, that's what a lot of our entrepreneurs are really focused on, is making sure that consumers feel like they're in control of some of those costs and in control of their own health.
That's very interesting.
Thanks, John.
We're gonna move it over to Don and Margaret, but what I'm seeing is the title of our program today is Medical Innovation More Affordable. And I wonder to a certain degree if we're just saying existing innovation more affordable, or some way of changing the dynamics so we're not necessarily enhancing care but lowering the costs as a primary lever to sort of accomplishing both of these things. So I know Don, you're up, and then we'll go over to Margaret.
Yeah, I think there's two ways of looking at it. I think one, certainly, unlike in the drug, which is the same thing, hopefully over time, in some of these computer-driven, or most of the computer-driven technologies, the actual product is rapidly evolving. So you look at CT scans. When I started in med school in the 70s, you could image the brain. It took 45 minutes. The only reason you could image the brain was because it didn't move. Around 1990, you started getting out motion of the abdomen. In 2002, 2003, the CT computer power was fast enough that we could image a beating heart. So I think there's just an actual change. There's a lot of innovation going on, even if you sort of think of it as a constant. The other big thing on cost is it's actually a global marketplace. So we're seeing in India and China and the developing world, Brazil, all kinds of major economies that are coming in at different price points, and that's being shared globally. So I think if we look at innovation globally, what we're seeing, certainly for the multinational companies that arbitrage this, is we're competing at every price point, and that's being shared globally. And it's, I mean, you see that, for example, ultrasound and CT, all of these price points are now determined by global markets as opposed to the historic U.S. market.
Mm-hmm. And Margaret, I think you wanted to comment also.
Yeah, so I think that we need to look at the issue that you raised around cost, but also the ease, some of the issues that were raised earlier. I think patients, we're all very busy people, and if we can go and buy our groceries online and everything else, I don't think anybody has any interest in making the medical process more laborious. I just had a routine physical, and my doctor gave me a bunch of paper slips to go follow up on. They're all sitting in a briefcase in Washington, so I can't act on them this week. That's not acceptable, and I don't expect that we're going to have that system that much longer. But I also think the issue that you raised around new treatments and new innovations, some of the things that were brought up in terms of CT scanning, there is a large number of diseases that do not have acceptable treatment. So I don't want us to lose sight of the fact that we have a medical research system that needs to be charging forward to meet needs such as the Alzheimer's epidemic or any multitude of cancers that if you're diagnosed with that disease today, there isn't a really terrific option for you. So I think that innovation has a number of different folders that we have to look at.
I think you're 100% correct, and I know that our topic is fairly succinct, but it really is very, very it's a very complex issue, and we fully recognize that. Our job here is to kind of be a catalyst for thinking. There are a couple questions that are coming in on Twitter, and I want to make sure that we capture some of the voices from outside of our panel now. And one question is, and maybe Amy or Stacy can jump on this, is this notion of crowdsourcing. Are we approaching a democratization of innovation and the ability to finance projects based upon this newly emerging notion of crowdsourcing? Where does that fit into the hierarchy of innovation and cost?
This is Stacy. Maybe I'll take that. Take a first stab at that and let Amy follow on. That's a great question. One of the things that's fairly obvious to us, we're sitting here in Silicon Valley, and we get far more than our fair share of startups walking in the door asking to collaborate with us. And I think one of the challenges facing healthcare specifically is the fact that the barriers to entry, regulatory, cost, privacy, all those things that make it more difficult to innovate as an entrepreneur lead people to head to the consumer space first, right? The risk-reward scenario profile is much poorer in healthcare than it is in the consumer space. And I think there's an opportunity to create a platform, whether it's folks like we have on this call, or the role of government or regulators or even academia, to begin to create platforms that actually make the activation energy lower for entrepreneurs to get started. I think that's pretty critical. Platforms like the ones that Qualcomm are putting together, or Lear Connect, right, are a great start to actually creating lower barriers to actually doing the crowdsourcing that we think is valuable.
And I think it's interesting to look at crowdsourcing from another perspective, and that can be actually the motivation of problem solvers or patients, and how we engage the collective to find interesting solutions. I think that what entrepreneurs did around creating a gaming-like interface to engage people who weren't scientists to help try different solutions and solve the challenges of determining protein folding patterns was an extremely interesting way to broaden the number of people focused on a biomedical problem. If you think about the gamification of patient performance and motivation, being able to break down a big, tough challenge like how am I going to lose weight or how am I going to stick to a better diet into very, very discrete incremental tasks and give small rewards for moving the dial. We've seen that work from new monitoring devices to what some innovative employers are doing in trying to motivate the people that work for them to be more healthy and thus reduce their costs. Being able to tap into the power of the collective to be able to solve those problems gives us a lot of opportunities.
Lisa, let me ask you a question, and I'm going to open it up to the whole group. We hear words like gamification as effective tools to help people manage their cholesterol or to lose weight, and this comes out of Twitter. Is the nature of innovation in health similar to that in the general sort of the other world or the consumer realm, or are the connections a force fit?
I think that there are some connections there, but we have to remember that this isn't in healthcare necessarily applying some new theory to how we're going to treat a patient. Honestly, when I look at some of the best clinicians out there, they've been using some of the principles of gamification for years without knowing that they're doing it. My team and I have done a lot of work in the patient-centered medical home. How do we reform primary care to do a better job at treating the whole patient in providing chronic disease solutions? And I talked to a nurse health coach who told me, the problem with trying to get patients to be more healthy is it's too big. So I find a discrete goal that they can go after. Let's just eat one sandwich for lunch this week instead of two. And then call me up at the end of the week, tell me how it's going. They have a moment of praise and they move on to the next thing. That's the same kind of jumping from level to level to level, that gamification, tapping into those motivations that it preys off of us. And this nurse in Iowa had been doing it for 5 years without knowing what she was doing. Now, obviously, there are a heck of a lot of innovators out there that can take that same motivation and apply it to healthcare problems, create interesting apps, devices to help patients do that if they don't have access to that nurse. But I think it's more of using our root human motivations and how we can actually change behavior to solve problems and applying it to the healthcare issues that we have to solve.
So maybe one thought to follow on what Lisa said. I think there's one distinct difference, especially with the role of gamification with regard to healthcare and how it might be different from the consumer space. You know, we saw Google Health and Microsoft Health Vault and Dossier all sort of fall by the wayside. You know, and the assumption there was that people were actually engaged enough, the general populace was engaged enough in their own health to actually want to engage, and then actually to then incur greater engagement through gamification. And I think what they learned was that's not actually true. There's a subset of the population, maybe someone who's acutely ill or managing a whole slew of family members who have chronic diseases or something like that that might incur engagement. But your average individual isn't as engaged with healthcare as they are with their cell phone or with their social network through Facebook, right? There's an innate motivation on the consumer side, which maybe doesn't necessarily exist on the healthcare, which you have to overcome first before you can start applying mechanisms like gamification.
Yeah, I think the challenge is that, you know, a lot of the activity are in the very, very sick patients, and so they're I think often the least able, just for reasons of illness, to sort of really get into some of these newer technologies. So I think the innovation there has to be directed in the context of that illness. Part of that challenge then becomes probably the set point to get through the FDA and to get reimbursement, and you really can't get paid in the U.S. healthcare system outside of, you know, sort of CMS kind of approved reimbursement for the most part. That's a $50 million egg, pretty much, to crack. And I think that really takes out a lot of folks who might be entrepreneurs. I think the gap to a large extent has been filled by academia, but I think it is a phenomenon worth noting that we rely on academics in healthcare for innovation far more than we do in any other sector of the economy, I believe.
You know, and I think that both of you made some very important points, and that is the issue of most of what we've been focused on in innovation is treating patients that are sick. And a lot of the problems in engaging patients, and let's even call them consumers, because when I'm not sick, I don't want to be called a patient necessarily. I have to engage you now in well care. And it is a whole different set of interests and motivations. And so, you know, I think when you look at the Microsoft and Google experiments, they tried to engage people who viewed themselves as healthy in management of being a patient and being sick. And that's not necessarily how people walking around on the street see themselves.
Let me, Diego, I want to call you into the discussion a little bit and get your perspective about the nature of innovation, particularly from the J&J world or the Janssen world, recognizing that in the world of big pharma, we're often seeking sick patients because that's where we make our money, and that well care and the ability to take good care of people who are not ill doesn't really fulfill the financial mission that is so essential to the brand. So take a step back and tell me about your perspective on innovation at Johnson & Johnson.
Yeah, and so I want to say something that may be a little bit controversial in this forum, but I was a practicing HIV physician in North Carolina for over a decade, and I was exposed to people that are incredibly underserved in rural populations in the South. And, you know, we tend to think that technology is going to solve all the problems. But I think technology is just a tool, and I think in many cases the interventions are about common sense, are about spending time with the patient, spending a lot more time with the patient, educating them. It's about making sure they can pay the copay. It's making sure they have transportation to come to the office. It's making sure somebody can measure their vital signs, making sure they have food. So there's a lot of very complex issues that technology cannot fix, and we tend to be very much of Luddites, thinking that technology is going to solve all the problems. So we have to be aware of what the limitations of technology are.
So I think that there are some very interesting issues that you brought up. Number one, we often look to technology to speed up an office visit, to have a quick algorithm or diagnostic mechanism where I can scan someone and be on my way. And that seems to be a bit paradoxical, that enhancing care may be about a more protracted or engaged relationship with a patient. And the question I have for the group is, to what degree is technology the driver of innovation, Or are we fooling ourselves by relying on the Qualcomm Lives of the world to create a technological infrastructure to solve our problems?
I guess this is Margaret. I don't think that it's an either or. I don't think it's all technology or it's all behavioral. I think we're talking about innovation in an ecosystem that has the tech-savvy patients, the very sick patients, the patients that Diego just spoke of, and so I think there's going to be different methodologies to hit all of them. But I think there's just more awareness right now that we need this innovation. I mean, some of the things that we're also watching closely are trying to understand why do we have hospital readmissions. So the Heritage Provider Network offered kind of an X Prize type contest just to understand, is there a mathematical algorithm that can identify based on patient records who's going to be readmitted? I think it's also looking at some of the psychosocial needs that Diego brought up. So are people going to emergency rooms or going to healthcare providers out of loneliness? And there's been some data that shows in elderly populations that they want human connectivity. So I think it's going to be a blend of all of this.
Any other comments on that? I think it's very interesting that when we talk about innovation, innovation very well might be an expanded use of a word choice or a compassionate engagement with a patient. And I would like to take a step away from technological innovation and talk a little bit about human innovation in advancing care. I know that they're contradictory in some ways, but anybody comment on that on the human side of innovation?
I don't think they're necessarily contradictory. I think we have a problem, and a problem, but the system is not optimal, and we all recognize the limitations of the healthcare delivery system that we have here and in the world. A lot of it is driven by fee-for-service as a financial transaction that establishes, how healthcare is reimbursed, and therefore the incentives are misaligned. I think a lot of you have to separate innovation from new ways of doing things, and a lot of it is about common sense. This is very important. It may not be glamorous, but it's about how we take care of people with much more common sense. Others may be novelty technology introductions. You asked me about a company like Johnson & Johnson looking at our core business product innovation, getting new drugs, and getting new devices to improve human life. But it is multifactorial, and we have to be looking at each of those pieces. But at the end of the day, we have to figure out how do we do it in a way that is where we get better value. Because what happens is we spend trillions of dollars, and still in our country we are number 19th in infant mortality, and we're number 18 in life expectancy. So it's still we're not getting a tremendous value for the money that we spend. And so therefore, I think that's the other innovation part. How do we pay for healthcare in ways that get better value to society?
I think that, Diego, you're absolutely right that there's a huge tie-in to, not only do we need the right technology, but we need to be thinking through the people model of how we're delivering healthcare. Interesting organization, Iora Health, who I think is one of the greatest innovators out there in how you deliver primary care to at-risk populations, literally rebuilding the model from the ground up. Putting together a care team, realizing that most of the time the physician isn't even the right person to touch one of those patients who has a chronic disease burden, socioeconomic needs, but a community health worker or a health coach can provide the hands-on support to get them the resources that they need to take down those barriers that are preventing a patient from being able to focus on what their hemoglobin A1C is. To do this, they had to remove the way that they were being paid for primary care. They take full capitation so they can deploy the resources that they want, build the care teams that they need, which has about 5 non-physician workers supporting one physician. And then they realized on the technology side that the technology that we have within a practice wasn't made to support the primary care team that they were building. Our EMRs are built to capture meaningful use dollars and make sure that our coding is up to speed. Wasn't what they needed to document the way that they wanted to treat the patient. So creating that product to fit the team that they have. Interesting interplay of how the right care team and the right resources can really achieve results.
Lisa, let me jump in real quickly because I want to follow up on one of your points. You said that with respect to maybe the EMR or technology in general in the clinical practice, is it retrofitted into clinical practice? Are we taking technology from, let's say, cell phones or other areas of technological innovation and force-fitting them into the healthcare environment? Is it done a little backwards? Should we reevaluate the way that's done?
Well, I think that there are two important points here. One is, what is the technology that we are actually putting into the practice that doctors are going to have on their fingertips? And I think the electronic medical record is a perfect example. And in that case, you have to ask, what were the business problems that we're trying to solve here? And for most doctors, it's that, I need to have a record so I can capture meaningful use dollars, and what the patient needs and what the physician needs to practice oftentimes comes second. When you talk about the connection between physician and patient, and are we taking a technology like a cell phone and trying to push it into medicine? I think the question we should be asking in that case is, what makes this easy for consumers or patients? Diego mentioned, the disadvantaged population who has issues around transportation. They're not going to have computers and monitors all over their houses. But you know what? A lot of them do have cell phones. And some innovators out there are using the cell phone to reach those patients. They may not have addresses, they may not have any consistency, but oftentimes they have a cell phone. So you can text them and interface that way to help to engage those patients. Maybe even giving them the cell phone is the answer. A Medicaid program in the Northeast decided with low-income expectant mothers that giving them a cell phone was worth the money if they could constantly reach the patient, remind them about prenatal care, and by sticking to the program, those mothers earned minutes for the cell phone, so they got their reward, to bring back to gamification. So I think we always have to make sure that we're solving the right problem and that we are using solutions in a way that consumers use for things other than healthcare.
Excellent points, and those are important. I want to go over to Stacy, who is gonna comment also.
Yeah, apologies. I hope you can hear me okay. My connection is a bit slow. I want to reinforce what Lisa was saying, and actually the question, John, that you're asking. In our view of the world, we spend a lot of time here at IDEO with technology, and really technology is no more than an enabler. In some cases, enabling things that you can't do, and so it's uniquely powerful. But I think we always want to begin with the needs of the human base. Whether that's the practitioner or the patient, or as we're calling them, the consumer, which I think is more appropriate. We work with a lot of healthcare systems, and one of the things uniquely we have to deal with is that, and we haven't addressed this yet actually, is that the medical education component that most of our doctors, I'm married to one, right, who have been, the medical education system that they've come up through really hasn't helped them focus on the human needs as much as I think is going to be necessary in the future, right? Understanding a patient, how to manage and how to engage them in a way that's more than just seeing them as a set of clinical symptoms and signs and therapy recipients. I think what Lisa's point is well made. The notion of care teams and actually surrounding that physician who's very classically trained, and then surrounding them with people who are actually more focused on the patient experience and guiding them through a critical therapy that that they have very little wherewithal to actually understand or even to traverse is actually going to become really, really important. So, most of the things that we've addressed with the healthcare systems is actually solving the human issues first, oftentimes by declaring that we're actually not going to patch anything with technology. We're going to go solve for the human issue first, understand at a very fundamental level what's driving the kind of behaviors that's causing inefficiencies, and then if there's an opportunity for technology to actually enable that to happen better, then we'll take advantage of that. But it shouldn't begin with the technology play, because you see over and over again things bandaged on top of each other. We saw systems where there's a core EMR with a communication system, with a lab system, and they're just all hacked together and in a way that they thought each time would solve a specific issue, but at the end was really just very, very convoluted.
Stacy, I think
I think the consumer sovereignty, if you will, is going to be really, it's sort of a function of not having consumer shopping. to the extent consumers shop, I think the system and physicians, no matter what they're trained, just basically rise to the occasion, which is sort of human common sense and just a very retail way. Some of the technology, though, some of the innovation, even relatively simple things can have big impacts. And if we think we need something really, really complex, we don't necessarily. If you look at electronic medical records, simply having a list of the patient's medical problems and a list of their medications is extraordinarily powerful to coordinate care over time. It actually automatically hooks up to pharmacies and stuff electronically now. So something that's basically a list, right? So a very simple technology has been enabled by computers. And so I think it's these combos of things that really are going to be out there. And we want to, I think, let clinicians discover that as much as possible. We obviously, as Lisa would point out, have a lot of this guided by a very tight set of meaningful use requirements and sort of a very funny reimbursement system. But I think if some of these things are left in a more market thing, you'd have a lot of responsiveness. It would be every mix of simple and complex, and the complexity would be hidden.
Interesting. You know, there are a lot of interesting words that came out of this discussion. The whole notion of education, of motivating patients, and I think that's something that we're gonna want to touch on a little bit more. But I want to bring in a question from Twitter. Lynn Levine asks that many claim that healthcare industry in general is resistant to innovation, and when we look at innovation from a broad perspective, who are the innovative companies in the world, and who are the innovative business sectors, and where does healthcare fit into this? Maybe we can go to Diego.
Yeah, I wanted to take issue with the comment a little bit, because if you think about where healthcare was 100 years ago and where it is today, public health has definitely had a lot of the measures that leads us to have much better lives, especially clean water and vaccines. But at the same time, I mean, a lot of the interventions provided by the healthcare industry have been amazing. I mean, in terms of life expectancy has changed in the past 30 years, has added another 7 years in the past 30. And that is due to a lot of the innovation that we do every day. If you look at the number of devices, the number of drugs that come to the market, I mean, like where diseases like HIV, that when I started practicing in 1985, 1/3 of my patients died every year. And now people don't die of HIV anymore, and that happened over a 15-year period. That was an incredible technical innovation that conquered a disease. Many diseases are being conquered by the innovation of the healthcare industry. So there's tremendous innovations around product and interventions. There has been less innovation in how we deliver that care in an optimal fashion, in a much more cost-efficient fashion. So I think that you have to separate. You know, the product innovation has been remarkable to the innovation about healthcare delivery that has definitely lagged behind, and that's what we're concentrating on right now. How do we optimize healthcare delivery?
But I think to add on to Diego's point about giving the HIV/AIDS example, you're absolutely right that the reason I think that we were able to come up with the treatments that we have today is because of patient involvement and consumer involvement, if you will, that they push the envelope throughout the system, at the FDA, at the NIH, with pharmaceutical companies. And I think everybody looks back at that example now and is really trying to understand how did they do that. So I think, I agree with you completely in terms of, we haven't taken that kind of forcefulness in the way that care is delivered. And I think, all of us have made this point, though, that I think more and more patients are, kind of, demanding that out of their health care. And I think that we're going to see more of that as it starts to become available. I mean, my husband is in a system, a Kaiser system, and he has a beautiful, electronic medical record that, he just can look at a moment's notice, and everything is right there. So that's the area that I think everybody wants to see is everything a little bit more, easily accessible for them.
So I think healthcare also has a lot to learn from other industries as well. I think that whoever asked that question, I think that speaks to sort of one of the solutions, which is, especially looking at consumer health. turning to some of these other organizations, like there's a book, If Disney Ran Your Hospital, right? Looking at ways that we can deliver care in a more personalized fashion. And Rock Health actually did some research on this, looking at ways that consumer health can be more personalized. So I think what we've learned is that innovation in healthcare can take bits and pieces from other industries and should look to other industries for the good, and leave out what might not fit.
Yeah, I'll reinforce what Diego and Margaret were sharing, which is that I don't think healthcare is necessarily resistant or unable or lacks the courage to actually innovate. I think the challenge is that they're hamstrung by the siloing that naturally happens by virtue of all the regulation that we apply to healthcare, right? It's easily the most regulated industry in the world. And when we work with every stakeholder in the ecosystem, they're trying to innovate inside a really tight box of regulations and capabilities and wherewithal and privacy issues. And frankly, they can't do as much as they have the courage to do because they're not allowed to, right? One of the things I find most compelling in the last few years is seeing the kinds of innovations that happen when you get those individual fiefdoms to actually align, right? So you think about something like onset of therapy, something like 31% of scripts never get filled, and it's almost exactly consistent from everything from like cancer to asthma, right? It almost doesn't matter what the disease state is. People don't start, and they don't start not because they forgot to fill their script. They've got deeper seated emotional issues that have to be addressed, right? They don't believe they have the disease. They don't believe the drug will do something for them. They're in denial, whatever that happens to be. Well, it's interesting because there are a lot of entities in the healthcare ecosystem that are interested in seeing that happen better, right? So pharma would sell more drugs if people would start their onset of therapy better. The retail sector, the pharmacies would fill more scripts if people would get on their therapy faster. The healthcare systems would be more efficient if the patient started. The insurance companies had lower costs, and uniquely we saw one collaboration among all four of those that had a huge impact on onset of therapy. And it's in those alignments between the healthcare ecosystem stakeholders that I think a lot of the innovation will happen.
Interesting. Stacy, and maybe the team can comment on this. We often speak to innovation revolving around the patient, to engage the patient, to make the patient more active, whether it be using something as simple as a text message to drive compliance. But we have a question in from Twitter that revolves around the notion of engaging physicians, nurses, and medical students in a technological context so that they own it, if you will. I think we see sometimes the non-compliance is not only in the inability of patients to take a pill, but the non-compliance of healthcare providers who do not embrace innovation, technology, or new thinking. Is that a problem, and how can we confront that?
Yeah,
I wanted to add to that, which is, is for those physicians, if you could speak on behalf of your profession, is it that physicians don't want to be boxed in? If you think about the book, The Checklist Manifesto by Atul Gawande, he talked a lot about why do we have checklists in a construction site, but not in an operating room or in a care delivery system.
Well, I think the challenge is that in fact patients are biologically unique. And so part of the challenge is how much of sort of the guidelines and those kinds of things actually really work. When it's studied, for example, guidelines in congestive heart failure have had great increases in compliance, percentage compliance and guideline, zero improvement in patients' outcome. So I think there's a personalization of medicine component here that I think really needs to be looked at in a more sophisticated way than we have been. On technology, so in my other life, I'm in the clinical faculty at Penn, and I see both old doctors and new doctors embracing technology. The one thing I've noticed in the 30 years I've been in the tech healthcare business and practicing is they're very efficient on their time. And so they're not going to embrace any new technology that makes them less efficient. And I think for those of us who are in the innovation business as well, that is usually the number one explanation for a technology not being adopted is it doesn't work, rather than that they just are resistant. I know that a lot of people think differently, but as somebody who's trying to sell that stuff, I can assure you that is almost invariably the root explanation for why something's not adopted.
Yeah,
So
Don's absolutely right. I mean, if an MD is not engaging the technology, it's probably because it was designed poorly. We've got a whole generation of people who grew up on technology asking for it in the clinical space now.
I think there's a bigger seed change that we are seeing happen, particularly in the physician space, where the craft of medicine is changing. And, medicine was largely based, how we treated patients was based on what individuals knew and had in their head. And honestly, that's how doctors are trained. When I was an intern, I spent my first night in the CCU. It was me sitting there, trying to figure out what to do with the patient who was coding. Fortunately, I had a team of nurses behind me who actually told me what to do. But it's the information that was locked in your head that had the value that allowed you to come up with a unique solution for each patient. With the explosion in medical information that we have available about our patients, what research is bringing to the collective wisdom of medicine, there's no way one human can ever even scratch the surface on that. And I think that as we see new physicians entering training who are more focused on technology and team, there is an increased chance that we will see doctors embracing this rather than seeing it as cookbook medicine, but seeing an engine like a Watson that can take that medical information and digest it into guidelines that are starting points for physicians. You're standing on the shoulders of giants rather than being forced to follow a protocol. And I agree completely with Stacy and Don. Any tool that takes advantage of this has got to be something that is additive to a physician's daily processes and isn't something that hinders and puts more clicks into every patient visit.
Lisa, let me jump in, and I want to make sure that we touch on one thing, which I will argue could be a linchpin into both innovation and cost, and that's the concept of the electronic medical record. We don't have a lot of time left, but I'm curious what the panel thinks about A, the nature of the adoption, and B, and how critical that may be into the full integration of information and cost effectiveness.
Yeah, we spend a lot of time with the Office of the National Coordinator working with most of the EMR vendors, and actually we spend a lot of time working directly with EMR vendors. And I think if we can be frank, the state of the EMR systems right now is basically to help hospitals capture their billing information more accurately, right? And that makes a lot of financial sense to them. It's a reason for adoption, certainly. But whether it's the EMR industry itself or someone who just figures out how to deliver value on top of that, at some point those EMRs will only become databases of information if they don't help the physicians practice more efficiently, right? They are critical. Whether it's the EMR system, which is got a huge head start right now, or somebody else who does it, the management of the knowledge network. Lisa talked about the tremendous amount of data that we're just generating on the research and diagnostic and clinical side. That has to be managed and utilized in a way that physicians can uptake, and so it's absolutely critical.
The problem I think with EMRs is that I agree with Stacy. I mean, having personally been involved in building the first Windows EMR ever back in the 80s under Windows 2.1, I think we've sort of made the paper chart electronic, but what we've done almost nothing of is automation, right? I mean, most of the rest of the world uses computers to automate things, right, to get people out of it, and we've used EMRs almost to get people even more stickily, that's probably not a word, involved in things. So we really need to radically rethink, and that's, I think, the challenge in a meaningful use world where some of these things are maybe even going in potentially the wrong direction and making it more labor intensive, right? Meaningful use is a labor intensive increasing activity where we want to think about the EMR in terms of things like presence technologies and things that are truly automatic, where there's no human involved. And that's going to be, sooner or later, the evolution, and we're seeing that a lot of other consumer things, whether it's a Fitbit or, all of the cell phone enabled type of technologies. But that's where the EMR, I think, will go, especially as capitation and bundling takes out the billing issues.
Okay, well, listening to this conversation is a little bit like trying to drink water out of a fire hose. The content is most engaging. A lot of really, really interesting comments, and our idea here is, of course, not to solve problems, but to begin to advance the dialogue. And I think we've taken some great steps on behalf of our panel who have contributed to this discussion. But also I want to thank the members of the TEDMED community for contributing their comments to this discussion. These dialogues are very, very important, and as we move forward, they will only continue to become more and more robust. Finally, I want to thank the Robert Wood Johnson Foundation for sponsoring the Great Challenges program. There's important work to be done, there's important thinking to be done, and we thank you all for your participation. And just let me leave you with one comment. In today's complex and advancing world, great challenges demand great thinking. Thank you very much for your participation.
Thanks.